All right, hello, welcome to chapter 23. Today we're going to continue the topic that's kind of similar to CFS that we talked about last time, chronic fatigue syndrome, but this is, off another branch of that. And then for the other video for this week, we'll talk about um, spinal cord injuries, stroke, and TBIs. Um, yeah, so this right here, chapter 23, will be the last one in the train of like CFS type syndromes that people may have. So, what is fibromyalgia? Maybe you've heard of it, maybe you haven't, but we will talk about it. It's a complex multidimensional condition and it's a clinical syndrome. So this is characterized by widespread musculoskeletal pain in addition to a variety of other multisystemic symptoms. So things like fatigue, sleep disturbances, cognitive dysfunction, stiffness, and depressive episodes. Now, it's a really elusive condition and it has many triggers. There are two things that are used for the diagnosis. The first one is widespread pain index, or WPI, and then the symptom severity scale, SS. So basically, to categorize it, someone has to score either a 7 for WPI and a 5 for SS, or a range of 3 to 6 for WPI and an SS of 9. So it's not only widespread pain, it's not only severe pain, it's basically like that combination of it. And sort of like CFS, in order to get diagnosed, the people would have to have these symptoms for at least 3 months. Now, just a little bit of statistics of, how common this is. It's estimated about 2 to 4% of the population get diagnosed with FM, fibromyalgia. That's just what I'll call it from now on. And that's about like 5 to 10 million people in this country. And then regarding who's more susceptible to it, it does affect both men and women. However, 80% of people are afflicted are women between the ages of 20 and 55. So, yeah, again, for a variety of reasons. Now, to continue with this, um, kind of like CFS, the etiology is relatively unknown here, so we don't really know why this occurs, how it happens, what that mechanism is, but there are thoughts. So we think that there are four main reasons, and it's probably a combination of these. So muscle abnormalities is the first one, so this might be due to stuff like muscle microtrauma or local muscular ischemia. It could be related to neuroendocrine and autonomic system regulation disorders. So stuff like HPA axis disturbance, which we've talked about in the past, as another possible reason for other conditions. And then diminished local muscular glucose metabolism, and so on. The third is central augmentation of pain processing. Now, this is thought to be maybe from the serotonin metabolism abnormality or decreased activity of the descending antinociceptive pathways. And there's actually some research that's really looking into that second one right there about the antinociceptive pathways. So that could be the lead to understanding FM more. And then lastly, much like many other conditions we've talked about, genetic predisposition also just may play a role, right? So, what precipitates FM? Researchers think it's four main things. The things that basically allow it to kind of occur: physical trauma, emotional trauma, brain chemistry disturbances, and altered sleep patterns. And the idea is these can trigger FM by activating some underlying physiological abnormality for someone who is genetically susceptible to it. So like the right combination of things happening and FM gets triggered. And there's also a really interesting um I guess like conceptual idea about FM. So research has suggested that exercise induces mild analgesia, which is essentially the dampening of pain. Now, if that is the case, then there's a theory that these neural pathways may be dysfunctional in people who have widespread chronic pain syndromes. So this tie hasn't been made with, exercise like specifically for these populations. But again, just theoretically, if exercise can induce mild analgesia, then maybe that is what the problem is. Because since it's a syndrome, and the cause is unknown and it's not related to other conditions, then it has to come from somewhere, right? So maybe the research is heading into this direction to explore it more. Okay, so how do people manage this? Well, there's two main ways, or I guess a combination of ways. Now, first, just to clear it off, a lot like CFS, it's a syndrome, right? So any condition that may have similar symptoms has to be excluded before the diagnosis is made. And that just to cover grounds and make sure that, it's not a condition that actually does have a treatment, right? Now, unfortunately, there is no known cure for FM, and so we use pharmacologic and non-pharmacologic interventions. So, for the non-pharmacologic, patient and client education is a big one, and this includes stress management and relaxation, aerobic and strength exercise, CBT, as we saw from last time. And then regarding the pharmacologic treatments, we have antidepressants and chronic pain medications. Also, people may be prescribed hypnotics, which help with the onset of sleep. So, depending on who it is, if sleep is a big problem for them, then hypnotics may be a part of it too. Okay, what are the effects on the exercise response if someone has FM? Just a note here, and I've mentioned it, I think, every lecture, but this isn't the case only for FM, but pharmacologic treatment can contribute to altered exercise response. So really take a note of what medication they're taking, and it may affect your exercise plan for them and their response to that exercise plan. Also, musculoskeletal symptoms and fatigue affect the exercise response. So, we're talking about widespread fatigue and symptom severity, right? The two scales that we talk about for FM. So, a lot of that is going to play a role in how people feel. So, they'll have a lot of morning stiffness, they'll have exaggerated DOMS. So, all of us get DOMS, but they'll have it even more exaggerated. They have poor recovery from exercise, which kind of stems from the DOMs. And they also have difficulty with use of the arms in elevated positions. Now, something to note about all of this, and we'll talk about it with the recommendations at the very end of this lecture, but exercises like eccentric exercises are not recommended. Anything that requires overhead, like pressing or overhead movement, that's also not a great idea. So these are some of the main effects that you have to account for when you're making a treatment plan for them. So how does exercise help with FM? So specific exercise doses are not known to improve FM symptoms, and actually this population takes really well to stuff like strength training, where research has shown that they actually improve uh, well, in a research context at least, they tend to improve quicker than non-FM matched people. So just the general population. So um, we don't know exactly what that dose should be, and that's going to be for you to figure out with your client or your patient with FM. However, there are some known benefits for specific FM symptoms that exercise can help with. So some of them regarding those clinical points, it can reduce the number of tender points that they have. So that's, with that widespread pain scale, the WPI. Decreased pain at the tender points, so reduced myalgic score, and then decreased general pain. So all of that is very positive because you're getting right at the symptoms of FM, like the main characterizations of FM. It also helps with a lot of other things in general, like improved sleep and less fatigue, fewer feelings of helplessness and hopelessness, more frequent and meaningful social interactions, and a lessened impact of disease on daily activities. All right, should you do an exercise test or not with an FM population? It can be helpful because most people with FM are typically deconditioned and sedentary, so it can be quite helpful to just see where they're at before you begin. However, there are a few things that you may need to note. So, as I mentioned just about a minute ago, they may be extremely deconditioned, and a lot of them are sedentary. So, note that it's probably not a great idea to do a maximum test. Stuff like sub-max tests are probably better suited for them, but it depends on the person, right? And then because this is essentially like another type of chronic pain syndrome, rating of perceived exertion can be altered. So either because of the drugs that they take or in general, like they just feel more pain than they should, right? So just note that. And then ideally, because of their poor recovery, test on a day when other activities are not scheduled. And definitely tell them that post-exertional muscle pain may be severe 24 to 48 hours after testing, just so they're aware that it's not going to be great, right? Okay, now exercise recommendations. So, interestingly, and this is probably a bit different than most of the other conditions we've talked about in lectures so far, but the main goal for an FM population is to restore and maintain physical functioning. It's not exactly cardiovascular or metabolic improvements. And this really differs because, CFS, sorry, not CFS, FM is the one that's kind of dictating how they're feeling, like it's the thing at their forefront. Now, this population may have other conditions, right? They may have hypertension, they may have atherosclerosis, right? But if FM is the main condition, and it seems like it tends to be for certain populations, then restoring and maintaining physical functioning is the goal. So progressing them is the goal here. Now, it's recommended that you use the CDD4 recommendations that we've talked about numerous times, and if possible, build up slowly to the ACSM guidelines. So that's very feasible, very possible with this population. And now here are some notes that you should take in case you ever do work with anyone with FM. So use of a standard cycle may be limited due to gluteal trigger points. So everyone's different regarding their diagnosis of FM. If the gluteal region is where some of those trigger points are, then a standard cycle is going to be really uncomfortable. So choose just the seated one instead, or another form of exercise. Avoid morning exercise because of that joint stiffness that we talked about. Um, Here's that overhead activity statement again. So a lot of people with FM have rotator cuff impingement and muscle weakness in general with the shoulder region. So just avoid that with them. Minimize eccentric movements to minimize the effect of DOMS. And then low to moderate intensity exercise is very appropriate for this group. So start with fewer than 3 days per week initially, and then progress slowly to 150 minutes per week. And again, if they are doing well, then move them along to ACSM guidelines. Also, regarding what they can do, warm water exercise is actually really helpful. And it actually, there's a note in the book that, it might help with moodiness as well. So that's good. And of course, we know that there's a lower risk of adverse musculoskeletal effects, and it has a lower effect on joints, lower load, right? So, warm water may be a good idea if that's available at a clinic. And then also, positive positive results have been shown with Tai Chi and yoga. So all of that is quite helpful for this population. And one final note that I'll leave you with that I mentioned for CFS. So this population is pretty similar to CFS in that they may overdo exercise if they're feeling good. Now, obviously, CFS and FM are not the same thing. They're quite different. However, these populations are really similar when it comes to that. And it's unfortunate because if they overdo it one day, then they may feel really, really terrible for the next day or two, maybe the next week, and they decide that they don't want to go back to exercising. So that's like honestly worst case scenario for either of those populations. So again, just err on the side of doing too little during a day because you still want them to come in every day. And this group has a really high dropout rate from exercise training. There's also a note that if you refer a person with FM or you are the person working with FM, then sometimes group settings are really good. especially if the group instructor can ensure that the person with FM is not overexerting themselves on a given day. So those are just some notes. But yeah, that's fibromyalgia. And then we will be shifting gears for chapter 25. Have a good one.